Welcome, everyone, and thank you all for joining our panel titled Agentic AI in Revenue Cycle Management, What's Actually Working. So, we're very pleased and humbled to see over 450 healthcare leaders who have registered for today's webinar. I think it'll be a fun conversation on a topic that is right now red hot, Agentic AI within RCM. The agenda for today is this. We'll be about 30 to 35 minutes and we'll end off with about 10 to 15 minutes of Q&A. So we'll start with some intros and then we'll get into the specific current state challenges of RCM. We'll then go into the why and the vision of basically 8 AI agents that we've designed specifically for revenue cycle management, and then the how. So this is the most important piece. How does this actually work? How can an AI agent actually help RCM and decrease the manual work? And specifically, we'll focus the majority of our time within prior auth and eligibility, number two, referrals, and number three, claims. We'll end off with the vision of the product and the vision of what an autonomous RCM organization looks like. And lastly, we'll end off with Q&A. With that being said, let's do some introductions. So, Zia, how about we start with yourself? How about you do a quick intro of yourself and then we'll go to Rano.
Sure. Thanks, Gib. My name is Zia Buddha. I'm the CEO here at OpenBots and very excited to be a part of the panel today.
Excellent. And Rano?
Very nice to see the audience today. My name is Rano. I am the head of healthcare at OpenBots, and I'm extremely excited to speak about a topic today which I'm deeply passionate about, which is agentic AI to make sure hospitals are paid faster.
I love it. And myself, Gabriel Skelton, I am the head of artificial intelligence solutions here at OpenBots, and we are a platform designed to help healthcare providers run autonomously. Let's talk about the current state of revenue cycle management. So, what's happening now is that regardless of the innovative technology that exists today, most revenue cycle teams are still working in a siloed way where there's still the majority of low IQ processes today are still done manually. And now, what's happening is that unstructured data is a huge piece. 70 to 80% of healthcare data is still unstructured. That means PDFs, free text notes. Let's not talk about faxes, but of course we have to. So faxes still account for over 3/4 of all provider to payer communication. And that very large volume of incoming faxes has had a lot of manual work on the back end. And basically, although technology is evolving, teams are still understaffed, overworked, and burnout is unfortunately a constant reality of a lot of folks within the healthcare industry. Now, there are 8 critical workflows that are still largely manual that we'll basically get into. So number one, and I'll actually share my screen here so we have a visual to go alongside. All right, for those watching visually, you can actually see my screen. So basically what's happening here is that fax indexing and classification. So when you're receiving those incoming faxes, that takes up a lot of manual work. And what's happening right now, if you go into the referral side, is that 88% of patient referrals are still booked manually. And this matters because when it comes to denials, 44% of denials happen right at the front end of the revenue cycle. And now talking more about eligibility and verification. So 24%, so basically 1/4 of denials are specifically tied directly to registration and eligibility issues. So solving that significantly helps across the revenue cycle, and it happens right away. And one of the areas you're getting a lot deeper into is prior authorization. Now, turnaround time is key here. This is not just about, hey, let's automate prior auth and it's good to go. You can automate tasks all you want in the submission of a prior auth, but if the data is incomplete or incorrect, you are not solving a problem. You're actually creating a problem. So that's a huge piece to make sure that the agent is smart enough to make sure the data is accurate before it submits a prior auth and doing it as quickly as possible. That's a very big piece because prior auth is one of the areas that is least outsourced across the revenue cycle, mainly because timing matters. So providers tend to want to have full control over that and do it in-house, which is awesome, but obviously using automation is the way to do it as fast and as smoothly as possible. And lastly, claims. So claims is the last piece we'll get into. And the point here is that the amount of claims that even a small provider receives, you cannot possibly get to every claim manually. Automation is the only way to address each claim because of the volume when done right. Zia, now let's move into you. So basically, these challenges we're discussing here today are exactly why we designed these role-based AI agents to take over these workflows. And the goal here is to help providers invest really in the front end to be as patient-centric and as patient-facing as possible and automate as much as possible in the back end and all the low IQ processes. So Zia, tell us more about why we've developed this set of agents, if you don't mind.
Yeah, thanks, Gabe. So we spend a lot of time analyzing these issues within the healthcare RCM industry. We also analyzed different companies and their approach to solving these problems. And what we realized that just like the healthcare industry itself, which is so fragmented in the United States, most of the solution providers also have a very fragmented set of solutions. So even with so many EHR systems out there and so many different workflows that are built on top of EHRs, there's still a very large number of people, whether it be offshore or onshore, operating these systems. So these challenges with these workflows, in our view, typically boils down to, as what you said, Gabe, is unstructured data, but also unstructured workflows. And I'll talk a little bit about that in a second. But so it's unstructured data, unstructured workflows, patient-provider communication, and a vast set of payer-provider rules and regulatory compliance. I mean, that's kind of like at a high-level view of, these challenges. So our approach at OpenBots is twofold. So while we designed these AI agents to solve a problem by automating a specific workflow, for example, prior authorization, end to end, we also created an AI framework to account for all the challenges, um, to handle the nuances within each provider-specific unstructured workflows, right? So this is where, and this is only possible with the new generative AI and the new fine-tuned LLM models, that have been in existence for the last 2, 3 years. So, at a high level, before we go into the details of the entire workflow of how OpenBots work, because we want to focus on the substance, and less so on the, abstract conversations. We're just going to talk about exactly how we actually solve the problem. So, at a high level, the OpenBots platform starts off by capturing process-specific data using OpenBots case management and patient data extracted and classified from various sources. It uses that data along with a multi-layered workflow automations to keep the process moving through the HR system and the associated workflows. I mean, OpenBots is, by the way, integrated with multiple EHR systems. We have API-based integrations through FHIR or HL7 interfaces, or even through the RPA, which is the UI based integration. So our platform is handled to manage the unstructured workflow. So let's say an unstructured workflow is a rejected prior authorization due to some sort of payer rule or other issues. And our platform keeps the process moving through the completion while giving the provider a real-time dashboard and KPIs, and the process status. And during that process, if there is patient communications that are needed, they're handled by the text messages, which is also integrated into our system. At this point in time, we don't think voice AI is still optimized for the real world, I mean, especially when it comes to healthcare. So we focus, specifically on the text messages or human in the loop exception handling. So in a nutshell, I mean, our mission at OpenBots is to create a clear path towards an autonomous RCM organization which continuously fine-tunes itself for an optimal provider outcome and even better patient care. So that's why we exist, and that's why we decided to go all in solving these problems. So I'm going to hand over to Rano. Rano is actually going to talk about some of the specific areas and how we actually solve the problem. So we actually want to talk and we actually want to show you the architecture of how our agents actually work. This is again going back to the thing that I talked about, that we are going to be focused on substance and not just abstract talk. Rano, on to you.
Zia, first of all, thank you so much for laying the platform. And if I may ask Gabe to share the screen on some of the AI agents that we can start discussing about.
Sure.
On today's topic, we are looking to cover three areas in particular. We are looking to cover prior authorization, we are looking to cover referrals, and also claims processing and denials management. From our experience, we have seen that these are the three areas which have always been a bit of challenging for specialty cares and healthcare providers in general. So, Gabe, why don't we start with prior authorization? Perfect. Here's the slide is up. Now let's talk about AI agents. Now we have been hearing about AI agents from different vendors, but we thought it would be interesting for us to give the audience today a clear picture of how we define AI agents. Now, behind the AI agents, there are large language models. OpenBots have invested a lot in language models over the last 2 years. And language models are sort of the powerhouses. They are the reasons why the AI agents can make decisions. Now, when you talk about AI agents, it does two things. It can pick up the task and perform those tasks, but it can more importantly choose the tools to perform those tasks. So these are the two things that we are looking at. I want to straight away go into this architecture of ours. So for any AI agent to work on, the first thing that we need is a process trigger, which in this case is a prior auth form. What we are looking at is a prior authorization form that came from the requesting provider and is currently sitting within your practice management system or EMR. Now that is the trigger for our AI agent to get activated. The first thing we do is we have a process request form. Essentially, it means we have a document processing engine that can go into that particular queue where the prior authorization form comes in. It can classify it as a prior auth form, and it can extract all the details of the patient and the provider in it. By that, I mean it can extract the patient's demographics, it can extract the patient's name, date of birth, it can extract the diagnosis codes, the treatment codes, and also the provider's information and the NPI. Now, once that data is gathered, we right now have the second automation that goes into the EHR. It queries for the patient, and it grabs the primary medical payer of the patient whose prior authorization it needs to obtain from. That's part of the first prior authorization request form that we are defining it. Now, the reason we call it AI agents is because not at any point in the process we want to bring in a human just like that. We want to have this automation technology work one after the other, triggering one and each other, and then it's doing it semi-autonomously or autonomously as long as there's no exception handling, like Zia said. After the authorization data is extracted and we have gathered the medical payer of the patient, the next thing we do is insurance verification. Let's take an example here. Let's say the primary medical payer of this patient is Regions of Blue Shield. We already know that Regions of Blue Shield is covered by a clearinghouse like Avality. So what we do instead is we take our bot, it goes into Avality, it then will first check whether this patient is right now eligible and has a valid plan on Regions of Blue Shield or not. The way we do it is by accessing the Avality portal and putting in the patient's ID number and date of birth. Once we get to see that this particular person right now has active coverage, so he is having the insurance benefits, we straight away go into a section which is the third bot in play on the screen, which is pre-authorization request processing. Now, what happens here? For requesting any pre-authorization, there are multiple lumps of information that you need to put to the portal in order to make sure that we go to the status. The type of information we right now have to put into the Avality portal or any payer portal includes all the patient demographics, all the referring physician's demographics, the NPI, the diagnosis codes, the treatment codes, the prior authorization's date of service, and the limitation, like whether the prior authorization is going to remain valid from today's date till the end of 6 months or 9 months. And then finally, we need to check whether the information of the servicing provider is equivalent to the information of the requesting provider. Now, whatever I just defined, this is a work of a data entry operator. It's simply looking at the prior authorization form and filling in the information. So our technology is set up in a way where it can exactly mimic that workflow. Now, once the authorization details are filled in, there are typically two types of scenarios that happens based on the type of payer you're interacting with. If you're looking at a payer like Regents of Blue Shield, in many scenarios, these kind of payers do not need any medical notes to be attached to give you the authorization. So it can straight away process the authorization. In that kind of a scenario, we get to see that no authorization is required. This kind of a status pops up on Availity or any other particular payer portal. We take that screenshot of the status, we capture it, we convert it into a PDF, and then we attach it to the patient's chart within the practice management system or the EMR the medical practice is using. That's the end of authorizations for payers, where you can see that authorization is very clean and straight through. But then we all know there are payers like Medicaid, Medicare, where you are not going to get an authorization so easily. What are we doing in those circumstances? When we come to a stage where the payer is asking us for some kind of a medical note, at that point, our agents are intelligent enough to go back to the patient's chart within the EMR, go to the medical notes section within the patient's chart, query through the necessary medical notes, bring the relevant information, and then take it back and upload it to the payer portal. And then because it's bots, it can come back after a frequency of 2 days or 4 days or 6 days to see whether the insurance payer has reviewed the information and has given the authorization status or not. That's essentially what we are doing. We have been doing this right now for the last 1.5 years with the latest technologies. And we have seen that this is giving a lot of productivity. This is giving a lot of time, staff hours back to the business. If I have to add one particular stat behind prior authorization and why this has become such a challenging topic. So across multiple surveys, we have constantly seen that 80% of physicians report that prior authorization is classified as a high or extremely high burden beyond the administrative hassles they have.
It makes sense, Ronald, and especially because so many non-urgent procedures, I think it's close to almost 100% of non-urgent procedures typically require a prior auth. And if an appointment is scheduled and that auth has not been approved, well, that causes a lot of issues for providers. Let's move on to referrals. I think it's a very important piece I'd like you to touch upon because every provider receives a plethora of just incoming faxes in so many formats. There's consultation notes, prescriptions, there's referrals, there's medical records, there's all these different documents that come in. And even on the referral side, referrals are always in different formats. So it causes a lot of delays and even closing the loop, which just stalls things heavily for a provider, impacts the patient negatively, makes them basically have leakage in referrals. But tell us a little more about that because when it comes to that, a lot of providers have been hesitant because there's so much unstructured or semi-structured data, especially with referrals. Tell us a little more about how you can use technology and how agents work there.
Yeah, absolutely. Now, referrals, as you rightly said, it's a big problem, and not just referrals alone. Handling incoming faxes is a big problem, if I may say, because this specialty cares, large health systems are receiving, 20, 25, 30,000 easily from the bunch of faxes they get in, right? What we are looking to discuss here is referrals. Now, like I said, we have AI agents that are going to be activated based on triggers. So the trigger for us when we handle referrals is the new incoming fax. Now, I want to take a step back before I go into referrals because a large problem of handling incoming faxes is just not, taking data from referrals and creating a patient within an EHR. That's still a substantial problem to have, but a bigger problem is any health system has no control on the type of referral formats they get from their primary care physicians, referring physicians, or different providers. They don't have a control on that. What they do have a control on is one structured referral format, which they can share with their referring physicians, but that's not often followed in the healthcare system. When we get a new incoming fax that comes in, the first thing we do is essentially we index and classify those faxes. And I'll define what I mean by indexing and classification of faxes. As a health system, you can have one fax line or one fax batch, which has a cluster of 150, 200 faxes that came in all together. The first problem that you're trying to address is essentially segregate all those 150 faxes into different buckets or different categories, which is 20 of those 150 are referrals, 30 of those 150 are prescriptions, 50 of those 150 are, let's say, medical refill forms or consent forms. OpenBots has been, capitalizing on unstructured data extraction for a very long time. We have been, doing a lot of R&D in this. What we typically do is we use AI models which are contextually aware. It does data contextualization, meaning it can tell you that a format of fax that came in has the word RX written on top of it. So it's a prescription based on the models it has seen in the past. So the first thing we solve is classifying the faxes into different groups. Now let us, go back to the example that is displayed on the screen here. Once a new incoming fax comes in, and that is classified right now as a referral, the first thing that happens is the intake bot's action. The intake bot is essentially going to grab that fax, is going to capture all the elements in the referral fax, which means it's going to capture the patient's name, patient's date of birth, patient's demographics, insurance information. It's going to capture the provider, referring provider's name, referring provider's clinic, if that information is there. It's going to capture all this information. It's going to then hand it over to the patient creation bot. Now, I'll tell you what the patient creation bot is. Think of a patient creation bot as a digital member in the patient intake team who is reviewing the fax, logging into the practice management system of the EHR, and creating a patient just like typing in the information he has seen on the fax. Exactly the same way we have the automation that works to essentially take the referral data and create the patient data within the EMR. The third thing we do is insurance verification. Insurance verification is a primitive process for most of the healthcare systems in the intake itself. We have by now, during the process of patient creation, we have gathered the insurance details from the referral fax, right? Now, let's say, for an example, we get to see United Healthcare is a primary insurance payer for the patient here. What we typically do is we take the member ID or patient ID and date of birth. We go into United Healthcare portal and we first try to check what is the insurance coverage or whether this person has a valid insurance under United Healthcare. We take that information, we push it back to the EHR saying like this particular patient has a valid insurance on insurance verification. So this is the third step that happens autonomously. So 3 things I defined so far: intake, patient creation, insurance verification. The fourth thing is appointment creation. Essentially, how do you create appointments within the EHR? Now, we do create appointments in 2 ways. One is we try to create appointments in a way where after the patient is created, we try to create a referral shell within the EHR for the call scheduling or appointment scheduling team from the hospital or the specialty care to come in. They have all the information they want right in front of the screen. All they have to do is call up the patient and confirm whether this date and time works for the patient based on the referring provider they want to visit. That's one step. But the other step is where we have been using AI models, but particularly for specialty cares who are using some sort of a patient engagement platform like Clara or Phreesia, or other specialty cares who are using a digital mode of communication with the patients like a message. We have the access to the provider's time schedules. We use our agents that have the access to the provider schedules that can pick up the time slots that is available for the doctor over the next 2 weeks. And it can take that time schedule, it can send information back to the patient in the form of a message and allow the patient to choose a time slot of his or her preference based on which we can notify the patient that, yeah, you have an appointment booked with this particular doctor on next week at Wednesday, let's say at 10:30 Eastern time. That's like, the bulk of what we do in referrals. But yeah, I'm very excited to see any question that pops up. Gabe, on to you here.
Yeah, we have a few questions. We'll address them in a second. But basically, the point you're making is that 25% of referrals require follow-ups. There's no-show rates as high as 30 to 40%, and patients can even wait up to 2 months just to see a specialist. So what you're showing here is that one AI agent is made up of multiple bots that take over the whole workflow. So let's talk about claims now, because in the claims world, I think it's about 10 to 15% of claims are denied. I think 42% of denials are preventable, and the issue is that 24% of denials are never, ever again recovered. So talk a little bit more on the claim side and kind of how that piece works too, Ron, if you don't mind.
Absolutely. I think one interesting stat about claims that I was reading through this morning is that, like you said, the average industry rate for denials is 8 to 10%. It can, easily escalate to 15% in situations. As a medical practice, and this is the interesting stat here, Gabriel and Zia, if you, as a medical practice, can prevent 15 denied claims, I mean, you can prevent 15 denials per month. At the end of the year, you can save $5,000 as a medical practice. That is an interesting stat that I found out today. And the other thing is 65% of the claims that got denied are never even reworked. So you're not only getting hampered in the first place, but also in the second place, you're not working on the claim that got denied because nobody wants to go into the mess of, doing back and forth with the insurance payers, and then, it's leading to nothing. Let's go straight away to the slide here, which is the claims processing piece. Now, for claims processing, once again, an AI agent is going to start from a trigger. The trigger for us is the services that is getting rendered. In other words, you can think about electronic claim that has been filed, which is essentially a digital version of the healthcare claim that you would send to the healthcare insurance company. Once an electronic claim is created, the first thing we do is claim submissions. By claim submissions, I mean we will send the claim to a clearinghouse, and the clearinghouse is going to take up that claim, and it's essentially going to send it to or transmit it to the particular payer associated with the claim. That can be any particular payer. Once the claim goes into the payer portal, this is where you have two scenarios. You either get to see that the claim is pretty much clean and okay, for which we straight away go in, we take the claim to push it into a payer portal, and we do claims adjudication. But in different scenarios, we have seen that the claim can have errors. It can have a lot of misinformation. In those situations, we send the claim back to the clearinghouse. It has to be cleaned up first. It has to be resubmitted, and then it will once again come to the payer portal from the clearinghouse. That's the first piece of what we are doing, if you see the bots section on the slide here. The other piece is very interesting. We picked up on denied claims, like what happens to the denials. One of the things we often do is AR follow-up process, which is kind of responding back to those claims which hasn't been given a response by the insurance company within the claim processing time limit. Now, that time limit could be 45 days, it could be 60 days. But if you think about from any medical practice standpoint, they would often try to recoup the payment from those denied claims. Like, why won't they? Right? That's a scenario we're looking at. What we typically do is we use the technology to log into the practice management systems or the billing softwares. We extract that queue that has got like 100, 150, 200 claims that were denied in the first place. We now try to see what essentially is the claim that got denied and who are the payers associated with it. Let's say the associated payer, for example, is United Healthcare. What will we do then? We'll go into the United Healthcare portal or any particular payer portal. We will put the individual member ID and date of service for those claims, and we'll try to see two things. We'll first try to see whether the claim status has been finalized, it has been partially paid, or it is fully denied. And then we would see the second thing, which is what are the patient responsibilities? Like, what's the service code for a particular claim? What's the copay? What's the co-insurance? After these details are collected, we are now going to understand why this claim was denied, what was the denial code, and what is the denial description. This is very important. If you get to track the denial code and the denial description, then only you have a chance to investigate further on to the claims getting denied. We capture all this information, which is like the claims getting denied, why are those denied, any payment details associated with it. Once we compile this information, we put it in the form of a summary report, and that summary report is then sent back to the billing software or the practice management system. The advantage is this: the AR team or the billing team is responsible to do AR. I mean, they don't need to spend so much time back and forth between two different systems, between three different pairs, just to look at some information which ultimately might not even come to use. So that's exactly what we are doing. One of the things that I haven't touched so far is the dashboards that you see on the right hand side of the screen. These AI agents are not just designed in a way where it can automate the process entirely and you perhaps need 3% or 4% of human intervention to come in. We have tried to design it in a way where even a CFO or a COO can come in and get to see an executive summary in the form of a dashboard. So, for example, when you talk about the AI agents for claims, we can give you all the details you want in the form of a dashboard where you talk about the claims processed, you talk about the claims that you have seen getting processed last month, so you can compare it head to head. You can look at the denials ratio, the denials rate. You can look at the top 3 or top 5 pairs so that you can put enough attention of your revenue cycle management team on the top 3 to 5 pairs to work on. So all the insights that you want to gather from the claims process is essentially what we gather in the form of a dashboard, and we kind of put it in front of you.
Excellent, excellent. So, Rano, what we'll do here is before we go to Zia's piece, we did receive. I'll go through one question, then we'll have some of the other ones for the Q&A section. But basically, the question is an excellent question: is how does the prior auth handle multiple CPT ICD 10 codes to authorize? Meaning, it's not a one-to-one relationship. So, I'll answer that at a high level. Basically, what we deal with that is this. Multiple CPT codes can be handled usually through grouped submissions if they're related. But to your point, each code must still be clinically justified. So what we do is the agent is smart enough to recognize multiple CPT codes, and what it will do is either raise an exception if it sees multiple CPT codes, or it would move it through a defined set of rules. And the agent continuously learns through every iteration, so then it'll basically modify each bot within it accordingly. As we saw earlier, every agent's designed through multiple bots. The bots are more simple, the agent is more complex. The agent is the piece that helps to handle more of that subjectivity or rule sets that may differ from what it already is programmed to do. That's the benefit of agents. It handles more subjective rules and not just the traditional one-to-one action. Hope that helped. Now, let's move on. With that being said, let's move on to ZSP. So we wanted to basically discuss kind of not just the how, but also the vision. So Z, if you don't mind, can you talk about the agent roadmap and the vision of what an autonomous revenue cycle management organization looks like? And you're muted currently.
Sorry about that. Yeah, so as I was saying, Gabe, earlier, when we looked at the, all the issues within the RCM space holistically, really a lot of things do boil down to unstructured data and unstructured workflows, right? So unstructured data, we can understand, you have PDFs, you have all sorts of documents, you have information that needs to be extracted, it needs to be moved along into the HR system. But the unstructured workflow is really what I talk about is, in most of these processes, there is a happy path, right? If everything, goes according to the plan, for example, a referral process, a prior authorization process just ends up in a, either it ends up in an approval or it ends up in a, an appointment being created in the system. But then you have gray areas, you have corner cases, right? So a prior authorization submitted can get rejected for multiple reasons. So how do you handle that, right? So that is where our system is designed to learn through different iterations. It is trained for every iteration that it comes across, and it is smart enough to, if it cannot come to a right conclusion, it can actually kick it back as an exception to a human. So there's a human in the loop concept in the system as well. The ultimate goal is to continue to reduce that human in the loop, to a point where it's, where the process is mostly autonomous. And if you think about it for a second, this is the same concept that you have in, in the desire to get the driverless cars onto the roads, and they're still not there. They can do a lot. If you can sit in a an FSD Tesla these days, there's a lot it can do, but there is that still that 1% that it can't do. And obviously, driverless car is a different problem. Solving a prior authorization, is a different problem. And I think if we can get these agents to 90% or 95% autonomous execution, I think there is humongous value to be unlocked for the providers, and not just the providers, but also eventually the patients, because it's all, at the end of the day, it's all about the patients. And a lot of times what we hear from the providers is, because of these processes, the patient care can be delayed, right? Because of the time that it takes within these processes. So our vision and our goal is to create a clear path for an autonomous RCM organization and just iterate through these corner cases and make the agents learn over a longer period of time.
Excellent. Thank you for wrapping that up. So that's basically the majority of the content. We were very efficient with time, and thank you, Rano and Zia. Let's now get into Q&A. We have several questions. We can kind of go through it. So basically, one question is that we received, and Rano, it's more on the dashboard. You can discuss this if you'd like. So how can a dashboard help track and reduce the percentage of denied claims over time?
That's an excellent question to ask. The dashboard is essentially the tracker for all the action the AI agents is doing within your business processes. Let's look at that way. So, for any automation, for any bots that run, we have the audit trails. We can get to see what are they doing day in, day out. So the dashboard is essentially a consequence, or it's a result of what the agents do within any business process. Now, obviously, as a medical practice group, you need to measure the number of claims that your team members are processing. You need to understand that out of the 100 claims that came in one particular day, how many got denied? And we are essentially taking those data, we are putting it in the form of a dashboard, and that's a super interactive dashboard we are talking about. It's not a dashboard which looks like a PowerPoint where you get to see the numbers here. So, it's almost like a click dashboard, if I may say, where you can click on a certain topic and you can get to see the details. Essentially,
Rano,
that's
I
how we
think
are looking
the
at
other
it.
thing that I would add is, look, if you look at any of these processes today, right, referrals or prior authorizations, anything like that, now think about it for a second. If you look at it from a process standpoint, there's no way for any executive or anybody to actually look at what's happening with their process today, right? It's just happening. People are doing it, but there's no insights into, how many are currently being processed, how many are rejected, those type of things. There's just no insights that exist. And having that insight in real time, I think it's very, very valuable. So I think that's really the crux of what the dashboards can give you. They can give you insights into your process real time.
Absolutely. Yeah, I agree with
Excellent.
that.
So I'll get into the question we have around kind of like missed faxes in a second, but the question we received from Malad was, how do you differentiate between a rejection and a denial? I can kind of cover this at a high level, and then we'll get to the faxes piece, and Ronald, you can discuss it. So basically, to differentiate, so in our world, basically, usually before a rejection is more like before the claim is actually accepted into the payer system. You usually do some kind of front end issue, like whether it's a patient ID that's invalid or it's a missing diagnostic code, versus denial is once the claim has been actually accepted and processed by the payer actually reviews the claim and then they decide not to pay. And they decide, hey, you know what, there was an incomplete prior authorization, or actually the coverage is terminated, or we just deem this as a lack of medical necessity, or a host of other reasons why they could deny it. That's where an appeal comes in, and we can actually automate that as well, the auto appeals. With that being said, Ronald, let's move on to the facts piece. So the question is, how do you handle missed or delayed prescriptions and lab results? And how does this impact timeliness of patient care?
Yeah. So, one of the cool things, if I say about this technology, is that it's going to run 24/7 if you want it to run 24/7. Uh, you know, you might have a prescription that came in at 8 o'clock in the evening where you don't have a patient intake person to fetch onto that at that point. The technology is there to run 24/7. You are the one who is dictating the terms and conditions of the technology. So typically how we address this problem is that we have bots that runs in a frequency of 30 minutes or 1 hour, and it will essentially go into the source, which is exactly where the faxes comes in. In your case, it could be, let's say, the EHR, or it could be a fax folder, it could be SharePoint. But we have the bots that are eventually going to run after 30 minutes or 1 hour, and it's going to track all the leftover faxes that it couldn't process in the last batch processing. So that's the way we can essentially make sure that we are not missing out on any particular fax, let alone prescriptions.
Thank you, Ronald. Perfect. This is a very good question, actually. So one question we received is, and then we'll get into the most, I think the one that Abbasit said about EHR is awesome, but this one quickly. On the prior auth side, how has automating oops, that's the wrong one. Question is, okay, curious to know, with payers having different formats in portals for prior authorization requests, how do you manage these variations, and how might AI simplify the submission process across multiple systems?
Yes, question for me?
For you, Ronald.
Yeah. Yeah. Okay, perfect. So the easy answer is we have seen most of the big payers and the small payers and the aggregators like Ability, One Health port a lot. So we kind of know how these portals behave. That's number one. But the question in itself takes me to the area which is a strong expertise of OpenBots, which is understanding something which it hasn't seen for the first time. Behind these AI agents, we are just not looking at a rule set where it would first have to identify a portal. It has to go into a particular area or dimension and then click on a button to go into the portal. Those days are long gone. What we typically do is a model called react, reasoning and action. So if we get to see that right now the portal looks different, that still allows us to move into the particular portal just like a normal medical biller would or a prior auth member would. And from there, it's eventually going to do the same steps that I just explained on the prior authorization slide, which is filling in the necessary information to get the auth details.
Yep. Another question, I think this is an also an awesome one. And again, I'll touch upon this. Ronald, if you wanted to expand on this, you can if you'd like. So, how does the agent access medical records from restrictive EHRs and or medical criteria from external sources needed to appeal? In general, the best way to integrate with an EHR that may be more restrictive is usually via HL7 or the user interface. In some cases, Fire. It depends on even also like ROI. Like in a lot of situations, you might be automating something, and then your EHR may charge you more money to do something via via the API. At that point, you go to the user interface layer, but it depends on that. The benefit obviously is agents can interact with systems even based on the screen. They can actually just look at the screen, and let's say that you have an automation or one of the bots is working on logging in to an EHR and it's in the top right hand corner. And then it moves to the bottom left hand corner. In the old world of like robotic process automation, that would break the bot. That's not the case here because the agent's smart enough to understand this is a login screen. Where the login is in the top right or bottom left, it's a login. So that's the general situation there. For example, like think about this on the coding side. We haven't really discussed this, but in reviewing a clinical note, AI agents are smart enough where they can actually review a clinical note and automatically grade it. So give it a grade like, hey, here's a B, here's an A minus, or hey, here's an F. This is a terrible clinical note. Based on what it's missing, it can then give a list of questions of what's needed additionally. So then it can go through those questions and try to answer it. For example, let's say there's a laceration on arm. An obvious question is, well, which arm? That's the kind of approach that an AI agent takes when receiving a clinical note because it has so much information it intakes and can use to decide on making sure that that clinical note is as robust as possible. Ron, I don't know if you wanted to expand on that anymore.
No, I think I couldn't have simply code you. So I think you covered all the main points here.
Excellent. I'm not sure about this question. I'll just throw it up there in case Zia or Rano, I mean, maybe you have to expand it, but are you also working on AI bots for concurrent reviews? Not sure I understand that question, but
Yeah, there is this thing. Yeah, it's one of the things that happens in in healthcare. But no, at this point in time, we're not working on the concurrent reviews. I think we're primarily focused on the 8 AI agents and really the corner cases, that happened within those AI agents and make them as smarter as possible. We are, although, outside of those 8 AI agents, the other thing that we're working on, very actually with several clients, is the patient communication part, specifically answering, wherever companies have deployed patient portals. We have the ability to actually um, uh, converse with the patients using the SMS messages.
excellent. So basically, like you're saying, say you have a specific portal where a patient can text a provider, right? And they have a question. It could be to schedule an appointment, to reschedule, to cancel. You're saying that with an AI agent, we can basically auto reply to all the queries instead of a person having to kind of, manage all of those incoming texts.
Correct. Yes. Yes. So I think that
And I can
Malad also gave us a clarity on what concurrent reviews are, interactions between providers and payers for inpatient stays. So thank you for that, but certainly not something that we're working on, but certainly that's, it's something that we can, we can look into.
Excellent. We'll do
give, I
one
think
more. Go ahead, Ronald. Go ahead.
give, I think on the point that Zia made about the patient interaction, I think let me take like 30 seconds to define the AI agent. I think that's an excellent use case where you can simply put these agents instead of still having people near shore, offshore, or onshore to do it. When you talk about patient interaction, there are three pieces within the AI agent that is going to be deployed. The first piece is patient interaction. Simply means you have a patient engagement platform or a messaging system where the questions from the patient comes in and you have to entertain that with resources. A patient can quite easily ask, hey, is Dr. Brown available next week, Wednesday at 11:30 Eastern time? We have a patient interaction model, which will first classify it and try to understand the intent behind the question. The second part of the model is what we call as data retrieval, meaning the question that was asked is Dr. Brown available next week at 11:30 Eastern time on Wednesday? The AI agent is smart enough to retrieve that data by accessing the time slot and the calendar of Dr. Brown. That's the second piece of it. So we talked about patient interaction, we talked about data retrieval. The third piece of the AI agent is response generation. Based on the data it is retrieved from Dr. Brown's calendar, which is 11:30 is an open slot, it can send back the message to the patient saying like, yes, Dr. Brown is available at 11:30 Eastern time on Wednesday next week. Do you want the appointment to be booked? That's what we are doing, all these three things together within the AI agent.
Excellent, excellent. All right, we'll go with one last question, and we'll probably have to end off there. So the last question is when it comes to it says that you didn't touch that much upon incoming faxes. How can it be possible to use technology to basically index and classify incoming faxes given the level of unstructured, how unstructured it is basically?
I mean, this takes me back to Zia's point about, if you're looking at 100 faxes, I mean, see, healthcare is fragmented. The way the faxes are handled is absolutely not the best way to handle faxes. We all know that. Because of the large data sets on which we have been trying to solve this problem for the last 4 to 5 years, right now we are at a point where one of our main areas is to kind of understand that the fax that came in is going to be classified first. Having said that, I do understand there would be corner cases, like Zia said, there would be exceptional scenarios where perhaps the AI is not smart enough to see a fax where you simply don't find any data which is written in a clean way. It's all messy and scattered. What we typically do is, like I said, we are focusing on data contextualization. So the models that we are using are contextually aware. even if it's a prescription that looks very messy in nature, but at some point in the document, it is able to trace the word RX batch. It can tell you that that particular fax is a prescription and not a consent form or a referral or a medical note. Now, there are scenarios where we are able to solve the problem at 92.3%, but then there are areas where we solve this like 98, 99%. Those 7 to 8% deficit that you're looking at, which an AI perhaps in 2025 is not smart enough to extract and classify and index, is what we can do with a modeling based on data set training. Now, if you allow us to kind of see those samples for a period of 30 days or so, I'm sure from next time onwards, the engine encountering that particular fax will be able to classify it appropriately.
All right. Well, Ronald and Zia, thank you very much for your time on this webinar. I think that concludes our webinar, called Agentic AI within Revenue Cycle Management, what's actually working. For those intrigued in looking at the recording, we're going to be distributing it on a one-on-one basis so we can discuss that. And those that want to learn more, you can always reach out to us via LinkedIn, or my email is gs@openbots.ai. I'll put it in the chat for everybody. Thank you very much for your time.
Thank you so much. Thanks so much, Gabe.
Thank you, everyone.